Thank you. Thank you for that kind introduction, and it's my great pleasure to be here speaking to you again this year about a subject which is very close to my heart, which is hepatitis B. And I'm going to talk to you about hepatitis B cure, and I've entitled this talk Reality or Fantasy. So let's just start by grounding ourselves. Why do we talk about needing a hepatitis B cure? And remember that hepatitis B remains a major global, but particularly a regional challenge. Over 226 million people affected and around an estimated 1 million dying per year. And to put it in context, that's similar to what Maria just talked about for TB. And in the Asia-Pacific, this is the data from the Western Pacific, but in the Asia-Pacific region, it's a particular problem. The average surface antigen prevalence is twice that of the global population, and deaths, as you'll be aware, caused by both liver cancer and the complications of advanced liver disease. And as you'll also be aware, WHO set global hepatitis elimination goals to be achieved by 2030. That's only 5 years away now. And this is data from the Polaris Observatory demonstrating that most of those goals are not going to be achieved till at least beyond 2050. Those are goals around diagnosis, around treatment, around reducing mortality. We're way off reaching those goals globally. In fact, the only goal that we are likely to potentially achieve is the one about reducing surface antigen prevalence in the under 5-year-olds. And as Adam mentioned earlier, cure of hepatitis B as a global issue will really be driven by vaccination because the majority of global burden is driven by mother-to-child transmission. And you can see there again data from the Polaris Observatory on the right showing that many countries are on track actually with their targets around vaccination and reducing surface antigen prevalence in the under 5-year-olds. But this is going to take years and decades to work through. And then in the meantime, we have millions of people living and dying with hepatitis B. So let's think about what we actually mean by hepatitis B cure. So there are many goals of cure, obviously, some of which are related to the individual and some of which are the population, and there are benefits to both. And they're around preventing liver disease progression, preventing hepatocellular carcinoma, about preventing transmission, about improving quality of life of people living with hepatitis B, limiting or eradicating pill burden for people who are living with hepatitis B, and lessening stigma and discrimination amongst people who are defined as being hepatitis B surface antigen positive. So there are many different goals of cure. But really, when we think about cure, we have to understand the hepatitis B life cycle. So I'm just going to take a couple of moments to talk through this because it's really important for the rest of the talk. So when we think about the hepatitis B, it enters here through the sodium toroscolate polypeptide transporter and goes into the cytoplasm of the hepatocyte, uncoats, and then goes into the nucleus of the hepatocyte. And here it forms something which is really important. It's a covalently closed circular DNA, triple C DNA, very, very stable form of DNA which stays in the nucleus of the liver cell. This is then transcribed into various forms of RNA and mRNAs, and then these are exported, and they actually undergo 2 different pathways. This is the pathway to make new virions here, which are eventually secreted, and this is where our current drugs work in reverse transcriptase. But here, many of the mRNAs are actually going to form viral proteins. This is S antigen and E antigen, which are being secreted in large volumes outside of the liver cell through a different pathway than this. The other important thing to recognize is that here, what can happen is after this reverse transcriptase process happens, some of this DNA will circle back into the nucleus and replenish this CCC DNA. It will also, some of it, when it doesn't undergo the right steps to form triple C DNA, will also form single-stranded DNA, but it will integrate into the host genome of the cell. So this is a very complex life cycle, which is important to understand when we think about how we're going to cure hepatitis B. And let's also think about what we mean by definitions of cure, because there are different definitions of cure. The sort of basic definition, if you like, is the partial cure. This is somebody who is not taking any treatment, has normal liver function and undetectable hepatitis B DNA, which is great, no liver damage, but they remain S antigen positive. And the problem is with that is that you have a high rate of reactivation from that state, and there is an ongoing risk of liver cancer. The second sort of step of definition, if you like, is functional cure. And the words functional cure are really important. They're used a lot in today's therapeutic development. And this means being off treatment, normal liver function, but having S antigen loss. So losing your S antigen positivity status for at least 6 months and possibly gaining a surface antibody, although that's not so important. So this is called a functional cure. But again, although the cccDNA here is transcriptionally inactive, it remains there. There is a low risk of reactivation, and it is really a remission and not a cure. When we talk about the next level, we think about complete cure. And in this state, there is loss of cccDNA from the liver nucleus, but those hepatitis B integrants remain in the DNA of the cell, and so there is still this lifelong risk of HCC. So the ultimate cure, if you like, is a sterilizing cure. And what we mean by that is not only S antigen loss, but also cccDNA loss, but also clearance of integrated hepatitis B DNA. And really that is the holy grail, but that is going to be incredibly difficult to achieve. So mostly when we talk about cure in today's world of hepatitis B cure, what we are talking about is functional cure, loss of surface antigen. And why does that matter if you can take a tablet a day that it keeps you undetectable, have normal ALT, etc.? Well, we know that even if you have, you're maintained on entecavir or tenofovir, whatever it might be, whether you are surface antigen positive or not matters. It matters for your HCC risk because you have a lower risk if you can clear surface antigen, and the younger that you clear surface antigen, the lower that risk of liver cancer development. So it's really important that S antigen is lost. Unfortunately, with our current therapies, entecavir, tenofovir, TAF, these drugs are great. They're very easy to take. They're safe. Almost everybody will have an undetectable hepatitis B DNA on these drugs. Unfortunately, the rates of S antigen are very low. And it occurs between about 2 to 5% of people after about 10 years plus on these drugs. So these drugs are not achieving functional cure. And when we think about cure, we also need to think about how we measure cure. So we have our current biomarkers, which is hepatitis B DNA, ALT, surface antigen, but we're going to get much more sophisticated as we move forward into a new era in terms of how we measure cure and what we're achieving. So things like quantitative surface antigen, hepatitis B RNA, hepatitis B core-related antigen. These are going to be new biomarkers of how we measure cure. And I want to just mention, firstly, quantitative surface antigen, because it's now a really commonly used clinical trial endpoint, as I'll show you in a minute, and also very important in terms of eligibility for clinical trials and for new therapies. Because we know that having a low quantitative surface antigen is a good predictor of end of treatment response and surface antigen loss. So knowing somebody's quantitative surface antigen rather than just whether they're positive or negative is going to be important. In terms of the other biomarkers, things like hepatitis B RNA, hepatitis B core antigen, these do not predict S antigen loss as well. But when you think about, okay, well, how are we going to want to measure in the future whether we're getting rid of cccDNA from the liver as a sort of better marker of, that more true cure, then these markers may be better, but they require standardization and validation, and we're way off using these in clinical practice at the moment. So we need better therapies, but we also need better ways of understanding and measuring hepatitis B cure. And when we think about going back to that life cycle, we can understand why it's been so difficult to think about curing hepatitis B DNA, curing hepatitis B. So if you look at that life cycle again, we've got this reservoir of this really inherently stable cccDNA that's sat in the nucleus of the cell. We've got integrated hepatitis B DNA in the host genome. We've got this complex life cycle with multiple different pathways. And we've also got this inadequate immune response. So most people remember infected in childhood or at birth, and this overwhelming secretion of these viral proteins into the circulation really induces a state of immune exhaustion. So the immune system is also not seeing the hepatitis B properly, it's not responding properly. So we've got a complicated life cycle and an exhausted and inefficient immune response. But what that means is that complexity also offers opportunity when we think about new therapies. So we can think about entry inhibitors. We can think about targeting CCC DNA in the liver. We can think about targeting the RNA, the transcripts that are going out to produce the proteins and the new viruses. We can inhibit polymerase. Well, this is what we already do. This is the step we do already address with our current drugs. But we can think about targeting S antigen production directly. We can think about targeting nucleocapsid assembly before the new virions release the cell. So these are all moments of the viral life cycle that we can think about therapeutically targeting. And then we can also think about approaches to restore hepatitis B specific immune responses. So you can see there's multiple places where we can perhaps interfere therapeutically to try and achieve a better cure. And that means there are many novel therapies now in development for hepatitis B. And these are the types of drug classes we have. And if you go to this website, you'll see all the different drugs listed. There are many of them, and I'm not going to go through all of them. Enough to say that they sort of tend to fall into drugs that inhibit viral replication. These are our typical, the nucleoside analogues, these fall here. Drugs that lower viral antigen burden, and then drugs that boost the immune response. So what I'm going to do is in the next few slides is just show you some of the most recent clinical trial data around some of these drugs, so you can kind of see where the field is going. So if we start with antisense oligonucleotides. So this is a drug called bepirovirsen, or I'm going to call it Bepi, it's easier. And I say it's the first kid off the block because it's probably going to be the first new drug for hepatitis B we may have had for a while. Bepi is an unconjugated antisense oligonucleotide, and it targets the RNA production, so it targets up here. So it's targeting the release of the surface antigen, etc., from the cell, the viral proteins. And data for the support of this drug came from a study called B-Clear. It was published in the New England Journal in 2022. And it took around 500 individuals, half were on stable nukes and half won't, and it looked at different doses of the drug with or without placebo. Now, the important thing, the primary endpoint, and it's the primary endpoint of most of the studies of hepatitis B cure these days, is having a S antigen loss, so a low S antigen below the limits of detection, and hepatitis B DNA also below the limit of detection, 24 weeks after the stop of finite therapy. So I just really want you to focus on these sort of coloured boxes here. But these are the people who are on nucleotides. These were people who are not on nucleotides. You can see they were pretty much the same. There was different doses and duration. But group 1, this is the first group in the orange here, and this is the primary outcome 24 weeks after stopping drug. This is S antigen loss. So you can see 24 weeks after they stopped, 9 or 10%, very similar in both groups, lost S antigen. So if you think how rare S antigen loss is generally in people on nucleotide therapy, you can see that this drug is really increasing those rates of S antigen loss. It was well tolerated. There was a bit of local injection site reaction and some mild ALT flares. And in fact, an ALT flare is really important because when this drug drops the surface antigen production from the cell, the immune system then is allowed to sort of respond and responds with an ALT flare. So it's a marker of success. The other important marker of success in this role of the baseline quantitative surface antigen, again, look at the yellow boxes, look at the 2 yellow columns, which were people who had surface antigen less than 3,000 or less than 1,000 before starting. And here you can see now S antigen rates are getting up to, loss rates are getting up to about 25%. So having a low surface antigen before you start therapy is really important in terms of who is going to get therapeutic success. 2 follow-up studies. One is to look at what happens when you then stop all treatment, and is that durable? And the other one is looking at the dose of Bepi 300, which was the group 1 dose, which is being taken forward versus placebo in people with low quantitative S at baseline. So this is the eligibility criteria, and that's probably what's going to be taken forward when this drug enters clinical practice, and it's just received fast track designation by the FDA, which is why I think it's going to be the first new drug we've had in a while. So so that was the first one of the ASOs, but let's have a look at these drugs here, some data, very interesting data, small interfering RNAs, again, addressing really the viral antigen rather than viral replication. This is a study released in the New England Journal just very recently, about 2 months ago. Zalnezirone, which is an siRNA with or without an immunomodulator. It's a phase 2 randomized open-label adaptive platform. The primary efficacy endpoint, again, is S antigen loss 24 weeks after the end of treatment. Like Bepi, it's a subcut injection. Patients in this study were all on nucleotide analogues. And here you have a number of different arms. There was a nucleotide-only arm. This is our standard therapy. And then different doses of the new drug, the siRNA, and then either with rosatolimod, which is an immunomodulator, it's a TLR7 agonist, or our more standard immunomodulator, pegylated interferon. So you've got starting to get combinations of drugs. And what I want to show you here, so this is 24 weeks after the end of treatment. This is the people on nucleotide alone, our standard therapy. Nobody lost S antigen. And here we have the siRNA added in, about 3 to 7%. But now when you combine it with an immunomodulator, in fact, you start to get much higher rates of S antigen loss. And in fact, the highest rate of S antigen loss was in the group who had the nucleotide plus the siRNA plus pegylated interferon. And they lost it, about a quarter of patients lost S antigen. It was only seen in those who had S antigen less than 1,000, though, at baseline. And this seems to be something that's coming through as a recurrent theme. And unfortunately, there was a bit of lack of durability. So when they followed them up for another 24 weeks, only about 60% of those individuals maintained S antigen loss. So unlike in the natural state, when most people lose S antigen, it's sustained. With these drugs, you might induce S antigen loss, but it might not be durable, and that's a problem. So finally, in terms of new therapeutics, let's just look at a very recent study, an early study, and this is now combining 4 drugs. So we're back to sort of the early days of HIV, right, when we've had to put together lots of different drugs, combination therapies addressing multiple modes of action. So this is a late breaker at the liver disease meeting, again, about 2 months ago. It's a study called MARCH. 2 new drugs, tobevibart, which is a broadly acting monoclonal antibody against S antigen, which acts at 2 places, viral entry and viral release, and elbisiran, which is a siRNA, again reducing the mRNAs. So these 2 drugs, both new drugs in class, and they combine them with pegylated interferon, immunomodulator, and standard nucleotide therapy. And what I want to show you here is remember the one in yellow is the 4-drug regimen now. This is early data, it's at end of treatment. But you can see the S antigen loss overall was around a quarter in the drug. People had 4 drugs. But in those people who had low baseline antigen at the start, it was around almost 50%. So this is getting up to the highest rates of S antigen loss that we've seen. And importantly, in this 4-drug combination, you had most people, or everybody who got lost S antigen also got S antibody, and that might be important in terms of durability. So we're starting to learn a lot about how we need to put drugs together. But there are some challenges in this current cure pipeline, as you can see from what I've shown you. The rates of functional cure are improving, but they're still suboptimal. Even in the very best scenario, we're getting up to less than 50% of people losing S antigen. So we're nowhere near sort of 80, 90%. Seroreversion can occur, and it's likely to increase over time, so the durability of these drugs is an issue still. And it looks like having an immunomodulator, something like pegylated interferon, which we've tried to move away from, is actually going to be a really important part of these regimens. And antiviral therapy alone is not going to provide cure for most. These new drugs are mostly parenteral, they're mostly subcut. We've had, once a day oral tablets for a long time, so we're introducing more complexity into the regimen. We're not sure which combinations we should use. Do we use them together? Do we use them one after the other? Do you have a siRNA and then add an immune modulator in afterwards to give the immune system a bit of a kick, or vice versa? How should you use these drugs together? Patient selection will be challenging because not one size fits all, and all of these drugs seem to work best in people who have a low surface antigen before they start, young and non-cirrhotic, and those are not the people who need cure probably most. And we're introducing added complexity of monitoring, so moving treatment back into specialist services. And finally, these drugs are going to be very expensive, as you can imagine. So we've gone again from having very cheap therapies, we're moving to an era where we may have very complicated, expensive therapies. And let's come back from fantasy to reality to remember that more than 3/4 of infections of hepatitis B occur in low and middle income countries. So we have to have also pragmatic steps to hepatitis B cure globally whilst we're pursuing all these new therapeutics. And in the last few minutes of the talk, what I'm going to talk about is actually some really important other work that is happening. And these, you probably may be aware of, these are the updated WHO guidelines released earlier this year. The last ones had been in 2015 with the Mother to Child update in 2020. And the reason for the change in these guidelines, which I'm going to highlight a couple of things, is the terrible statistics, even with our old guidelines. So 10% of people with chronic hepatitis B are actually globally diagnosed, and only 2% are on treatment. And in sub-Saharan Africa, less than 0.1% of people are on treatment. And if you look at hepatitis B birth dose, it's about 45% globally, the birth dose, and it's 18% in the African region. And immunoglobulin is rarely available in low and middle income countries. So, urgent need to revise the guidelines to get better people onto the therapies that we do have. So these guidelines, there were 29 recommendations across the whole spectrum. I just want to focus on a couple of things quickly. Preventing mother-to-child transmission. Adam touched on it, but what I want to highlight here is the very important recommendation that in settings where hepatitis B DNA or e-antigen testing is not available, which is many, all pregnant women who are surface antigen positive should be recommended for tenofovir treatment, irrespective of whether what the hepatitis B DNA is or not, because you don't know what it is if you haven't got it. So prophylaxis with tenofovir for all pregnant women who are surface antigen positive. Estimated to avert around 5 million infections if this is carried out on a global scale. And I want to highlight this. This is data also presented very recently in JAMA in November 2024. This is an important study because, as we mentioned previously, immunoglobulin is rarely available in low-middle-income countries, and it's expensive, but it is part of the guidelines to help prevent mother-to-child transmission. Now, this is a Chinese study, and here what they did was they actually randomized to standard therapy, which is tenofovir in the 3rd trimester, plus vaccine, plus immunoglobulin for high-risk mothers, to actually starting tenofovir at 16 weeks of pregnancy, so a longer course of tenofovir, using tenofovir for 24 weeks, not 12 weeks, without immunoglobulin. And what they showed was that basically a longer course of tenofovir and no immunoglobulin was as good as our current recommendations to include immunoglobulin. So this is something that is pragmatically easier to follow in many places than giving immunoglobulin, and is important data to for our knowledge. And finally, just something else about simplifying diagnosis. Again, if you can have the best treatments in the world, but if you can't get people diagnosed, you're not achieving what you need to achieve. And just a word about improving access to, because this is actually some work that our group has done at Kirby. We did the validation of the first hepatitis C fingerstick testing. We've just completed the evaluation of novel hepatitis B DNA fingerstick testing from capillary blood. on the Cepheid expert, which shows excellent correlation with venipuncture, and hopefully this will encourage Cepheid to support the development of a hepatitis B DNA fingerstick cartridge, and things like this can really help get people onto treatment and diagnosed. And we're also evaluating dry blood spot. So finally, what is required to make hepatitis B cure really a global reality? Well, I think the therapeutic drug pipeline is exciting. It's full. There's lots of things going on. But we need to invest in innovative clinical trial infrastructure and design to really maximize this. So adaptive platform trials that can drop in and drop out different combinations easily so that we can drop drugs that aren't working and add ones in that are working. But particularly, we need to do this in countries and in areas where hepatitis B is a challenge, and that means investing in infrastructure in low and middle income countries. Eventually, we would like to have a one-size-fits-all curative strategy, just like we have for hepatitis C now. That's really the end game, and until we have that, the complexity of the monitoring just really puts extra barriers in place. Strong community engagement co-design right from the start, right when these therapies are being developed. We need to bring the community of people living with hepatitis B into the design of the new therapeutics and talk about what's important to them in terms of cure. We need simplified test and treat guidelines. I think we have them now with the WHO guidelines. We need to now work on implementing those. We need to decentralize care back into communities to where people are living with hepatitis B. Tackling stigma and discrimination to enable people to come forward for testing and diagnosis and treatment. And of course, investing in hepatitis B primary prevention and keeping our eye on that, because that is going to be the only way we will eventually achieve global hepatitis B cure, as I've shown. So, final slide, hepatitis B cure, reality or fantasy? I talked some years ago at this conference on hepatitis C DAA development when they were coming through the pipeline, and I showed this slide which suggested there was light at the end of the tunnel. And I think that was true for hepatitis C drug development in terms of the DAAs back then. Unfortunately, I think for hepatitis B cure, we're still here, we're still reaching for the stars. I don't think we're there yet. I think we have a long way to go to really understand what we need to do in terms of the therapeutics. But I think we also need to remember there's a huge amount we can do with the tools we have to improve the lives of people living with hepatitis B today. And I think that's my final slide, just my acknowledgements. Thank you.